Good afternoon and thank you for joining us. My name is Robin Maggio, representing the National Resource Center on ADHD, and I'd like to welcome you to our webcast, Recognizing Challenging Behaviors in Young Children, Could It Be ADHD?, with guest expert Dr. George Depaul. The National Resource Center on ADHD is a partnership between CHADD and the Centers for Disease Control and Prevention that serves as the national clearinghouse for the latest evidence-based information on ADHD. Today's webcast is part of our Ask the Expert series, Educator Edition, providing information to teachers and educators working with children and youth who have ADHD. If you're looking for further information and resources about today's topic or ADHD in general, we have health information specialists available Monday through Friday between 1 and 5 p.m. Eastern Time. You can reach them at 800-233-4050. It is a pleasure to introduce today's guest expert, Dr. George Depaul. Dr. Depaul is a professor of psychology in the College of Education at Lehigh University. His primary research interest is the treatment of individuals with ADHD and related behavior disorders. He focuses on early intervention for young children at risk for ADHD, school-based interventions for youth in K-12 settings, and the assessment and treatment of college students with significant ADHD symptoms. Again, we're pleased to welcome this afternoon's guest expert, Dr. Depaul.
And good afternoon, everyone. I appreciate everyone's interest in this topic and your willingness to spend some time thinking about this topic this afternoon. I have obviously some information I want to share with you, but I also look forward to your questions on this topic area, and we'll get to that in a little bit. So the first thing that I want to review with you, you may already be familiar with some of this, but just to make sure everybody's on the same page, with regards to ADHD, particularly as it's exhibited in young children. First of all, just as a reminder, when we refer to ADHD, we're referring to significant problems that children may have with either inattention and or hyperactivity impulsivity. And that these are problems that are typically chronic and are happening on an everyday basis, and lead to impairment, which we'll talk about in a minute. So there are diagnostic criteria. The citation there, APA, is the American Psychiatric Association, 2013, published a manual that includes diagnostic criteria for ADHD and other disorders, and so that's where this is coming from. So ADHD, it's important to know that it is a chronic disorder. Even when diagnosed in young children, can be chronic for them through their lifetime for at least half, if not more, of young children with early symptoms. And in fact, some of the most recent evidence would indicate that it's chronic for many more than 50%. So 50% is kind of the minimum estimate in terms of chronicity of this disorder. Approximately 2% of 3 to 4-year-olds are can be diagnosed with ADHD, although, again, that's a figure that is on the lower side. Some of the more recent studies of the percentage of kids that have actually received this diagnosis at the preschool age would actually be even higher than this, 5% or even more than that. So one of the ways I always think about it is if you have roughly 20 kids in a classroom, or at least 20 kids in a particular classroom, that at least one of them will meet criteria for ADHD, and it's possible that more than one of them could have it. So all teachers in every setting are going to be encountering these kids on a pretty regular basis. The symptoms in young children, these symptoms of inattention and or hyperactivity, impulsivity, are associated typically with impairment. Impairment including problems with defiance and aggression, noncompliance, disobedience, that kind of thing, as well as problems potentially with learning letters and numbers in their early literacy, early numeracy skills. And in fact, some of the more sobering data would indicate that many of these children enter kindergarten already substantially behind their peers, not only in terms of behavior and behavior control, but also in terms of their literacy and numeracy skills. So, and not because they lack the ability to develop those skills, but because their behavior interferes with learning the skills. So if we go, let's see, to the next slide here, this presents to you just kind of a brief overview of what's involved in the diagnosis of ADHD in preschoolers. And this is comprised of several components. One of the main components is a diagnostic interview with parents regarding the DSM-5 criteria for ADHD and other disorders. DSM-5, for those of you not aware of that, refers to the Diagnostic and Statistical Manual of Mental Disorders, 5th edition. And again, that is the manual that I referred to earlier that's produced by the American Psychiatric Association. So these are the agreed-upon criteria that psychiatrists, psychologists, other mental health professionals use to identify what disorders might be present for a given individual. So what would be involved in this is to sit with parents for a half hour or so and run through not only the criteria with regards to symptoms of ADHD, but possibly, or not possibly, but definitely talk about other possible disorders that may be involved here. And I'm going to get to that in a little bit in terms of some of the things to think about relative to ADHD. Second piece here is that parents are asked to complete questionnaires about their child's behavior, not only with respect to ADHD-related behaviors, but also conduct problems, anxiety, disorder symptoms, depression or mood disturbance, their social behaviors with other kids, and so forth. I've put in parentheses here a couple of examples. BASC stands for the Behavior Assessment System for Children. It's a commonly used parent rating scale, published parent rating scale with normative data for the U.S. population. Another example is the Conners Early Childhood Rating Scale, which is a little briefer than the BASC. The BASC has many items. The Conners is a little bit easier for parents and teachers to fill out. It's a little briefer. But again, it has normative data with regards to ADHD symptoms as well as behaviors related to other concerns like conduct problems for a nationally representative sample. Similarly, we would frequently ask teachers to fill out a similar set of rating scales. And again, there's a teacher version of the BASC and a teacher version of the Conners Early Childhood Rating Scale. And so we want to get perspectives from the two individuals who spend the most time with the child in the most structured settings. And so that would be the parent and the teacher. One thing to note, if I just pause here for a second, it's really important to get parent and teacher perspectives on the symptomatic behaviors, because many times when a child goes to a clinic and is interviewed or evaluated with a mental health professional, they may not exhibit the same behaviors that they would show at home or at school because the clinic is a very different set of circumstances, and so the behavior there may not be representative of what you see at home or at school. So it's really important to get input from parents and teachers about what behaviors look like in those everyday settings. And to supplement that, to go to the fourth bullet on this slide, it's really, really helpful for the mental health professional to directly observe the child's behavior in one of their natural settings. You know, what we do, I'm a school psychologist, so obviously I'm focused on behavior in school settings. So what my colleagues and students and I do is we directly observe the children's behavior in the preschool classroom, and to see the degree to which the child has problems paying attention or being engaged with activities. Do they flit from one activity to another? Do they interrupt activities? Are they very fidgety and restless? Do they have problems in terms of aggression? And so it's really helpful to directly observe them in the classroom using a structured observation code. And the other thing that we will look at there, of course, is to what degree does the child look different from his or her peers in that classroom. So, for example, I've been to some classrooms where every child looks like they have ADHD. perhaps because of the structure of that room or the teacher's management style or whatever. It's hard to pick out who has ADHD versus who doesn't, because there's kind of a high level of chaos, if you will, in that classroom. On the other hand, I've certainly been in classrooms where, the degree of structure and expectation is pretty clear, and for the most part, kids are well behaved, and the child with ADHD sticks out much more noticeably against that background context. So when we go to do direct observations, there's kind of two purposes to that. One is to get information about the child's behavior relative to ADHD symptoms, but also to see what the preschool classroom looks like in terms of structure and activity and expectations and so forth. And then finally, a very, very important piece of the diagnostic workup for this age group is to rule out developmental disorders, particularly autism, because as you may all be aware, children with autism spectrum disorders also have difficulties with attention and impulse control and activity level, not necessarily as a function of having ADHD, but perhaps because they have a developmental disability. And with this age group in particular, autism is, the primary age where autism is diagnosed first is in that preschool age range. So it's really important to rule out the possibility that the child's attention problems or behavior problems may be due to autism spectrum disorder as opposed to ADHD. That said, kids could have both disorder and ADHD. That is possible, but it's much more likely that they have one or the other. So we want to make sure that we're going in the right direction. So all of you that are listening to this webcast, I'm sure, have experience with young kids and probably realize that there's a great degree of challenge of diagnosing ADHD in early childhood for a number of reasons. One is symptomatic behaviors that comprise this disorder are relatively common. And if you read the list of symptoms of ADHD in terms of difficulty sustaining attention to tasks and talking frequently and moving about, fidgetiness, so forth, it basically describes every 3-, 4-, and 5-year-old you know. Okay, I mean it's a description of the kind of behaviors that we would expect from this age group. So that's one challenge is evaluating this disorder relative to a background context of kids in general in this age group displaying some of these behaviors. Secondly, there's a lot of variability between children, among children in this age group in terms of their behavior and their behavior control. So it's hard sometimes to ferret out who are the kids that are having consistent problems with these symptoms versus those who have periodic problems with it or that's less consistent. So so at the bottom of the slide are some of the things that we really think about to try to address these challenges. One is that it's really critical to establish that the behaviors comprising the disorder are happening at a high frequency relative to their age group and their gender. I should mention that boys are more likely to display ADHD symptoms than girls. So if we are evaluating, let's say, a 3-year-old boy with respect to ADHD, then we want to have assessment measures in our toolbox that include normative data for what a typical 3-year-old boy would look like with regards to these behaviors. And that's where these rating scales, such as the Connors or the Basque, are really helpful because it does give us that background context. Secondly, we're looking for chronicity. That is, this is not just temporary behavior, in anticipation of, an exciting event, or it's not just a 1 or 2 day a week thing. This is something that's happening on a daily basis for an extended period of time. By definition, the diagnostic criteria requires 6 months of duration of these symptoms. However, some researchers in this area, such as Russell Barkley, a well-known ADHD researcher, suggest for this age group to be even longer chronicity for at least 1 year, so that we're establishing that this is not just a temporary phenomenon. This is something that is more ongoing. Thirdly, it's really important that the behaviors have to be found to be associated with impairment. So symptoms without impairment are not a disorder. I mean, that's something that I can't emphasize enough, that just showing the behaviors alone does not result in the diagnosis of ADHD. Those behavioral symptoms need to be associated with either impairment socially, academically, or behaviorally. So commonly what we would see with preschoolers with ADHD in the social domain is that they have problems getting along with their peers, making friends, keeping friends. In the academic domain, they're having problems because they're inattentive and impulsive. They're not making the progress that we would expect in terms of learning letters and numbers and some of those early skills. And then fourthly, I've already mentioned this to you, but just to reiterate, we want to make sure that the symptoms are not related to other disorders or developmental delays. The big one that we think about for this age group is autism spectrum disorder and similar developmental disabilities. But with older children with ADHD, the other things that we would think about is anxiety disorder or depression. Can sometimes lead to problems with concentration and attention, and we would need to make sure that that the apparent ADHD symptoms are not due to another disorder, again, such as anxiety or depression. So I'm assuming that many of you on this call are, or on this webcast are teachers or in the educational environment, and there's a very prominent role for educators in the assessment process. As I mentioned to you previously, it's really important to get the perspectives of the folks who are on the front lines in working with these children, both parents and teachers, because clinicians like myself, we only see kids in a short context, and if we're seeing them in a clinic environment, that's not very representative of what they look like in the classroom or at home. So teachers have a very prominent role here. Including some of the following. One is observing the child's behavior relative to their peers over time and across settings and activities. So these are three things to really think about. You know, what does the child's behavior look like in a normative context? How do they look like relative to other 3- and 4-year-olds that you currently are working with or you worked with in the past? Secondly, you know, what's the behavior look like over time? Is it consistent over time, or is it very specific to certain times of the year or certain times of the week? And then thirdly, how does the behavior vary across settings and activities? With ADHD, one would expect that the symptomatic behaviors are occurring fairly consistently, not necessarily across every activity or setting, but certainly across the majority of settings and activities, or more than 50% of them. If the behaviors are only happening, you know, let's say at circle time or free time play activity or, you know, very specific activities, but not at other times, then that would lead to hypotheses about, well, what's different about those settings or activities that's triggering these apparent behaviors, as opposed to a disorder that would cut across settings and activities like ADHD. Second role for a teacher is certainly to discuss any concerns that the teacher may have with parents in a very descriptive format, so non-accusatory, non-challenging, but just describing the behavior as it is viewed, not interpreting it in any way, not diagnosing, certainly. And so rather than saying, I think that your child might have ADHD, which would involve an interpretation on your part, it would be more helpful to say, I have concerns about Johnny's attention during certain activities. He's not as engaged as other kids. He's moving around a lot more than other kids. He's interrupting things and being impulsive more frequently than other kids. And so it would be describing those behaviors as opposed to interpreting them or going beyond that descriptive level. Thirdly, it would be important to encourage parents to seek an assessment of their child if the behavior is certainly severe relative to classmates, and particularly when it's associated with impairment. If you see, the child really struggling to get along with other kids and or struggling academically as a function of their behavior, then it would be really important to encourage an assessment as early as possible. Because, as I mentioned to you before, these are kids that may start school pretty significantly behind their peers, and so we want to try to prevent that if we can. The other thing that teachers may be asked to do, as I mentioned to you previously, a good clinician is going to ask teachers to fill out behavior ratings, one or more behavior rating scales. As I mentioned to you before, I gave you some examples, the Basque and the Connors. Because this allows for you to provide, structured information about various behavioral symptoms, and then the clinician would be able to compare the scores that you give the child on that rating scale to the normative population in the U.S. if we look at the role for parents in the assessment process, certainly they would want to meet with teachers to discuss concerns that the parents have, but also to hear the concerns from the teacher and to try to hear that in a way that doesn't become a defensive position. And again, this is where it's helpful if teachers are describing behaviors as opposed to making interpretations. It's less likely to engender or elicit defensiveness from parents. And similarly, if parents have concerns about what's going on in the classroom, they should be relaying those concerns to teachers in a descriptive way so that, again, it doesn't become a defensive context. Parents also certainly need to observe their child's behavior over time and across settings and activities, as I mentioned to you previously. With ADHD behaviors, we expect that those are going to be chronic over time, from day to day and week to week, month to month, but also across most situations and activities. Parents also should follow up on a teacher referral and follow up in an expeditious way. The teacher has concerns to the degree that they're making a referral for an assessment that should definitely be followed up on as soon as possible. And parents have a big role to play in the assessment in terms of working through an interview with a clinician and completing behavior rating scales, as I've mentioned to you previously. And then health professionals obviously have a role in terms of discussing the referral concerns with both parents and teachers, not just relying on input from one entity, but certainly getting information from both parents and teachers because they may have different perspectives. And they certainly are, the parents and teachers are viewing kids in different contexts. So for a clinician to really do a thorough assessment and a comprehensive assessment, they need to get input from both parents and teachers. It's very critical. And this is all part of a comprehensive assessment that's not just focused on ADHD symptoms, but also focused on other issues, developmental disabilities, autism, other mental health conditions. That may either be happening in addition to ADHD or may be accounting for what looks like ADHD. And then finally, I just want to briefly mention that there are constraints from both organizational and legal perspectives relative to ADHD diagnosis in young kids. One of the bigger challenges we have as school psychologists in my profession is we have a relatively limited opportunity to observe child behavior in preschool classrooms because the typical nursery school student, for example, may only attend preschool for a few hours a couple of days a week or three days a week. So in contrast to kids in K through 12 who are in school 5 days a week for 6 hours, there may be less opportunity and feasibility to getting observations done because the preschooler is not at the school as much, certainly not on a daily basis. A second constraint that I do want to emphasize is that educators don't diagnose ADHD. That's not the role of preschool teachers or educators in general, but rather to provide descriptions of behavior and the related concerns around impairment that those behaviors may be associated with. It's really important, there have been legal challenges in some situations. This has been K through 12, not in preschool, but K-12 teachers who have essentially diagnosed ADHD or told parents that they think their child has ADHD and that they should go get medication for it. And that's gotten people into hot water legally. So it's really important to not take on that role. Certainly you can have it in the back of your mind that you're thinking about that, but it's really important to emphasize the description of the behavior rather than the interpretation of the behavior. And again, educators don't recommend medication, but rather refer for evaluation, not specifically for medication, but for evaluation of what services might be helpful for a kid who has ADHD. It's important to note that, and I know that this web seminar series is going to be focused on treatment and succeeding webcasts, but the American Academy of Pediatrics for this age group emphasizes behavior therapy before medication as a treatment for young kids with ADHD. And this is for a variety of reasons that I'm sure you'll hear about in future webcasts, but it's really critical that as educators we're not directly recommending medication, but rather referring for evaluation for services that might be needed. And then finally, there are restrictions regarding communication of health problems. The HIPAA Act focuses on this, that protecting confidentiality of information about children's health behaviors, including ADHD. And so we need to make sure that we're following those restrictions and getting consent from parents, for example, before communicating any information to a clinician is necessary. A parent needs to provide consent for that exchange of information. So, and then I have some references for you that are provided at the end here, that if you're seeking further information about some of the concepts that I presented. But at this point, I'm certainly open to any questions or comments that anybody might have at this point.
All right, thank you. Great. So our first question is actually about the emergence of sensory processing disorder. So with the emergence of that, have you found, in your opinion or in your practice, that it's been more difficult to distinguish children with ADHD?
Yes and no. I mean, it is certainly a consideration. I don't have specific expertise in diagnosing sensory processing disorders. I would make a referral to other folks in that instance. The main thing that I try to concentrate on relative to that question is, with ADHD, you have a much more, you have a ubiquitous phenomenon of kids experiencing difficulties across a number of different settings, a number of different modalities of instruction, a number of different modalities of communication, such that it's not apparent that it's specific to certain types of activities or certain types of presentations. And so I'm looking for chronicity. I'm looking for consistency, cross-situation types of activities that that tap into that processing disorder, but that those attention problems would not be present when there are activities that don't tap into that sensory processing disorder. And so that kind of situational discrepancy would lead to the consideration of other possibilities, such as sensory processing disorder, whereas with ADHD, you would be most likely to see consistency across situations and across activities that would be counter to the idea of a sensory processing disorder.
Great, thank you. Along that same line, so diagnosing ADHD and having other factors that play into it, we have a question about, are there any cultural factors that you see that come into play when diagnosing preschoolers with ADHD? And if so, could you give some examples of those?
That's an excellent question. I don't know of data specific on preschoolers with ADHD, but there's certainly a fair number of studies that have looked at cultural differences in identification of ADHD among older children and adolescents, and there definitely is a cultural context here, a socio-cultural context. And so, for example, on average, African American children, obtain significantly higher teacher ratings of ADHD than non-African American children. And this is just in the general population now. So as you're looking at a normative group, not necessarily with ADHD, but if we have rating scales completed, on average, African American children get higher scores on those measures than non-African American children. So we need to, and those were done with K through 12 kids. Now I'm not talking about preschoolers, but my guess is that it would be similar. And so there's something about the rating scales in relation to differences in cultural expression, cultural thresholds that play a role here, that for me as a clinician, I have to be very careful when I use these measures with African American kids in particular, particularly if their score is right around the threshold of clinical significance. So if they're just kind of barely over that line, I have to wonder, I have to be, conservative in terms of the interpretation of that score. The interesting thing is that from a diagnostic perspective, African American children are significantly less likely to be diagnosed with ADHD than white non-Hispanic children in the U.S. So it's kind of an interesting conundrum. That one of the measures that we use, teacher ratings and parent ratings, would seem to suggest a potential over-identification of African American children. But the actual incidence of diagnosis in the country goes in the opposite direction. And there may be, various reasons for that. To the extent that race is correlated with socioeconomic status, it could be that poorer families have less, access to mental health services and ultimately to an ADHD diagnosis. But it could also be due to skepticism on the part of certain communities with regards to behavioral health issues and maybe a reluctance to follow through on an evaluation or treatment because of that skepticism. So we could go on and on about this. There's really a lot to talk about in terms of the socio-cultural context of diagnosis of ADHD. What I try to do in the absence of clear guidelines and information is to be as conservative as possible when thinking about this diagnosis, particularly with the African American population, because of this difference that you see, particularly in teacher ratings, but also to some extent in parent ratings. But I don't know of any specific research on this phenomenon with preschoolers. So I can't comment specifically on that, although I can't imagine that the situation's any different there than it is for kids K through 12.
Great, thank you. We have a question about the legal constraints with educators, and the understanding is that an educator does not diagnose ADHD, but what about if a parent asks a teacher if they think that their child has ADHD? Do you have suggestions for how a teacher might respond to that?
Yeah, I think, again, I would rely more on description. I would say, look, I can't really offer you an opinion on whether your child has ADHD or not. That's not my training to do that kind of diagnosis. But what I can tell you is that he or she's exhibiting these behaviors, and describing those as specifically as possible, and and also connecting those to any impairments that the child might have, and to say, you could even say, even in the past, I've seen these behaviors in other students who may have gone on to getting a diagnosis of ADHD, but maybe not necessarily. But again, I guess what I would emphasize is going back to the descriptive level of analysis and just saying, this is really not my role to diagnose, but I have concerns because these are the behaviors I'm seeing. They're happening at a much higher frequency than I see with other kids. And they are leading to impairment. The kid is not getting along with their peers as well as they might, and they're not learning at the degree that I think they're capable. And so it's important to follow up with a mental health professional and to explore, what the possibilities are, whether it be ADHD or something else.
Great, thank you. We have a question about, is ADHD being more prevalent now than in the past? Is it being diagnosed more, or is it just being reported more often? Can you provide any insight onto that?
Yeah, that's a question that we have some clear answers to in parts of that question. We don't have some clear answers to the other parts of that. So where we have a clear answer is there is very clear that more kids are being diagnosed with ADHD than in previous years. So the Centers for Disease Control, which your resource center is associated with, conducts surveys every few years about the rate of diagnosis of various entities, including ADHD. And the latest report from that group from a couple of years ago would indicate that about 11% of children under the age of 17 have been diagnosed with ADHD at some point in their lives. Now, that's not talking about preschool specifically. This is just over that childhood age range, 11%. And that's substantially higher than previous estimates from earlier this century, and even dating back into the late 1990s. There has been a systematic increase in the percentage of kids up through the age of 17 who have been diagnosed with ADHD. So that's very clear. What's not so clear is, does that increase in diagnostic rate mean that more children are getting the disorder than used to? So that, an increasing incidence, if you will, in the disorder. Or does that represent the fact that mental health professionals are more keenly aware of the symptoms of ADHD and are more likely to diagnose the disorder than in previous years just simply because of awareness? Or is it overdiagnosis? Are there instances where we are too keen to see ADHD when it could be something else? So people are making mistakes, if you will, in diagnosis is another possibility. But we don't have a clear answer to any of that, other than the fact that it is very clear that more kids are being diagnosed with ADHD than ever before, and that warrants attention to, looking at the practices of clinicians who are applying these diagnoses. Are they using the recommended best practices in a consistent way? And are we either under or over diagnosing? We don't really have a clear answer to that.
Great, thank you. I think that helps clarify. How do you deal with summer babies, children who are age appropriate, but they might just be less mature than their classmates? So they're born later in the year when compared to their classmates. Do you have any suggestions for parents and teachers to understand those differences better?
So is that in terms of the higher risk for being diagnosed with ADHD, or is it a question of holding a kid back, if you will, until they because they're one of the youngest members of the class, to hold them back to be one of the older members of the class? I guess I'm not sure what the question. I want to best answer the question.
Okay, I think the question is referring to that different expectations might be needed for children based on not only the fact that it's just a 3-year-old compared to other 3-year-olds, but based on sort of when they're born within a year. So I think it was more the first part of what you were thinking.
Yeah, that's a really good question. There are. It is very clear that, particularly in the early grades, there are substantial differences in maturity and behavioral control among the younger kids in the class versus the older kids in the class. And that tends to even out over time, but certainly in the early grades, that does become an issue. And from a diagnostic context perspective, again, this is where I really want to make sure that I'm using assessment measures that have good normative data, where I can tie the child not to their grade level per se, but to their age level in terms of expectations. So I'm trying to take into account what their expectations are based on their chronological age, as opposed to the expectations for kindergarten or first grade or second grade or whatever it might be, because there is going to be variance between the younger kids and the older kids in a class. That is a well-established phenomenon, and so a good clinician needs to take that into account. Particularly, as you said, when they're dealing with summer babies. Is this a phenomena related to developmental maturity that the kid will, quote-unquote, outgrow? Or is this a phenomenon that represents a chronic disorder such as ADHD? And it's not an easy thing to ferret out, but this is why we try to incorporate measures into our diagnostic evaluation that allow us to compare kids to others of the same chronological age. The same phenomenon, the same question could be asked about boys versus girls. The maturity rates among girls is faster than boys, particularly, in the early stages. And so, boys are going to present with less behavioral control than girls. And I'm not talking about ADHD, I'm just talking in general. And so, we need to take into account those potential gender differences when we're looking at evaluating ADHD, so that when we're looking at a boy, we're using a certain normative context relative to if we're evaluating a girl, we'd be evaluating that girl against other girls of the same age. So there's both an age phenomenon and a gender phenomenon that we need to take into account when we're diagnosing ADHD.
Great, thank you. Do you have any recommendations that can be provided when parents are closed-minded in regards to having their child assessed or go in for an evaluation? So how teachers, educators, school administrators might be able to encourage parents to be open to receiving some support?
Yeah, good question. I think, again, it goes back to some of the things we were talking about earlier, is to try from the get-go to not put parents on the defensive, and to be as descriptive as possible as opposed to interpretive about behavior. And because we have to keep in mind that because ADHD tends to run in families, it's possible that one or both parents could have had ADHD themselves or still do, and could have had bad experiences in schooling. And so they come into the school already kind of predisposed to kind of a feeling of failure or a feeling of ostracism. And so they already feel one down to you in some ways. And so it's important not to reinforce that perception of being one down by really being, hardcore about, we really think your child has ADHD. It's really, really important that you get an evaluation because, he's falling really behind. And, you got to do your job as parents and laying on the guilt trip or whatever. I think it's important, obviously there would be concerns in trying to make sure that they do follow up, but to do it in a matter-of-fact fashion, and in a descriptive fashion, and in a compassionate fashion of saying, really, emphasizing the strengths that the child shows and what the teacher likes about the child, and really emphasizing that and saying, I really want to make sure that Johnny or Susie starts kindergarten off right. And that may be a ways from now, but, it's really important because of these behaviors and the kind of impairment that Johnny or Susie is experiencing due to these behaviors. It's going to be really important to know what's going on before he or she gets to kindergarten so they can get started off in school the right way. So you're coming across trying to partner with them in terms of concern for the child, but in a way that's not accusatory, or it could be viewed as accusatory by the parents, and is very matter-of-fact and descriptive.
Great, thank you. And on the flip side, we have a question from someone who is asking, what is the best advice you could give to parents who believe they may have a child that might have ADHD?
Yeah, so again, at the preschool level, I assume, right? So
yes.
I think, the first step would be to talk about their concerns with other folks who know the child pretty well. And, of course, the most logical one at this age group is the preschool teacher. And to, set up a meeting with that teacher and say, if these are the kinds of things that I'm seeing with Johnny at home. Are you seeing this at school? Or do you have other concerns about him at school? And trying to get as much information from the teacher as possible. Because one of the things that's really important to realize is that teachers, particularly those who are experienced, have had a number of years of, getting to know what's expected of a 3-year-old or a 4-year-old or a 5-year-old. Whereas parents, particularly if we're talking about the firstborn in a given family, don't have that context. They don't have that history. They don't have that background to evaluate their child's behavior against. So talking with the teacher is going to be really critical. Assuming that the teacher has similar concerns, then the next step would be to talk to the child's pediatrician or family practitioner about those same concerns, bringing information from the teacher as well as from you as a parent to that physician, and seeing either whether that person would evaluate the child's concerns or more likely make a referral to a mental health professional who could do a more comprehensive evaluation of what might be going on. So I think the first step is to talk to others who have familiarity with the child, particularly the preschool teacher, and then bringing those concerns to the physician who works with the child, and then go from there. And certainly, there's a lot of information online and elsewhere that parents can get information from. I mean, obviously the National Resource Center being the primary place for that, as well as the CHAD organization. So there's a lot of good information out there. There's also a lot of bad information on the web about ADHD. And when I say bad, I mean inaccurate or harmful. And so it's important to make sure that if people are going to be looking at websites and other information like that, that they go to get accurate information. So the National Resource Center and CHAD in particular. But again, if you want to pursue it, if you have concerns about the child, then the best thing to do is to talk to the preschool teacher and then move on to the physician or family practitioner, and then go from there in terms of potentially a referral to a mental health professional.
Great, thank you. What is the youngest age in which most healthcare professionals can make a diagnosis of ADHD?
Well, there's no hard and fast rule on that. I mean, technically, nobody would do this, of course, but I'm just to prove to make my point. You could diagnose an infant with ADHD. Of course, nobody would do that. But there's nothing in the DSM-5, for example, that tells you the minimum age at which you can diagnose. I think in practice, most people are very, very reluctant to diagnose this condition with kids under the age of 3. Certainly, I have never identified anybody under the age of 3, and even between 3 and 4, it's challenging for some of the reasons that we talked about earlier in terms of the developmental expectations for behavior at that age and the variability in behavior at that age. So I would say age 3, in my mind, is the youngest to go. But there are 2-year-olds, thousands of 2-year-olds in the U.S. who have received a diagnosis of ADHD. So not everybody subscribes to that idea of age 3.
Okay, thank you. What about, can you give some specific examples of behaviors somebody might look for a child that might have the primarily inattentive ADHD within the preschool age? So what sort of behaviors would be considered inattentive at that age?
So it would be, their ability to sustain attention to an activity for the same amount of time as other kids would be expected to at that age. So you might see them flitting from activity to activity and not really being able to sustain focus for any extended period of time. You may also see them daydreaming frequently, so they're kind of off in space in terms of their thoughts and their focus, and they're not really focused on what's happening in the immediate environment, but more lost in their own thoughts. You may see them forgetting things fairly frequently. Forgetting to, you give them a set of instructions and they forget them, within a very short amount of time after being given those instructions. And it's not willful. You have to kind of, as best you can, determine what's willful disobedience versus just, lack of recall. So those are the sustaining attention, the engagement, the daydreaming, and problems with recall. Those, to me, are kind of the hallmarks of inattentive behavior in this age group.
Great, thank you. We have another question about other behaviors. Disorganization and forgetfulness. Are those behaviors you can track in the 3 and 4-year-old range as being concerning, or are those more for the school-age child?
Well, the forgetfulness, again, I just mentioned that. I think that's certainly something to track. And again, it's all relative to what's expected at that age. So that's where it gets tricky. You have to think about, okay, most 4-year-olds, 3-year-olds are not going to be able to follow, let's say, 5-step directions that are only, that are given once. They're not necessarily going to be able to follow all that, recall all that. But, they certainly should be able to follow 1- or 2-step or even 3-step directions with minimal prompting. So if you see kids, forgetting in that context relative to what would be expected and what their peers are doing, then that's certainly something to track. The disorganization, again, what level of organization do we expect for 3- and 4-year-olds? You know, what are the reasonable expectations for being organized? You know, to what degree do we expect them to be neat in their drawing or their coloring or other things that they do, you know, as part of activities? We look at what are the expectations in terms of organization for that age group, which are minimal. You know, that we certainly are not expecting a 3- and 4-year-old to be highly organized in the way that they attack tasks or the way that they keep their space up. And so, but that said, a young ADHD child is more disorganized than their same age peer. And so, again, we want to look at the background context of what those expectations might be, make sure that they're reasonable expectations, that others are meeting them for the most part, and that this is a child who's not able to meet them, and we can track that as well.
Great, thank you. Do you know of any electronic technological devices that are used to diagnose ADHD?
I know of them, yeah. There are certainly a number of these out there. Probably the most well-known and well-researched electronic, it's software. You know, it's not an actual hardware, but electronic software is the continuous performance test, which is a test of sustained attention and impulse control where, for example, a child looks at a computer screen for an extended period of time and random letters appear on the screen, and they're instructed to press a button or press a key on a keyboard when they see a target stimulus, let's say an X. Every time an X appears, you hit an arrow key or something on the keyboard. And then whenever it's a letter other than X, you inhibit that response. And so these are measures that are used in clinics fairly regularly, and as you might expect, kids with ADHD tend to miss the targets more than other kids, so these are called errors of omission. And they also tend to hit the key when they're not supposed to. They anticipate an X, or they quickly see the letter starting to appear, they think it's an X and it's a Y, but they've already hit the key. The behavior's already gone. So they make what are called errors of commission, which is sensitive to impulse control. That's probably the most widely known electronic assessment technique. I did not mention that as part of my presentation for two reasons. One is there's not as much data on the use of these electronic assessment measures with preschoolers as you have with older kids and adolescents. In other words, there's really not normative scoring data typically for 3- and 4-year-olds on these measures. So we don't really have a developmental context for that performance. And then secondly, I would rather spend the time, rather than having them do these kind of one-on-one measures that are not necessarily representative of their real world, I would rather go out and observe them, you know, in real-world settings, interacting with other kids, interacting with teachers, interacting with parents, and seeing what their behavior looks like under real-world conditions, because that can often give me much more information, both diagnostically and in terms of treatment planning, than using an electronic measure like a CPT.
Great, thank you. I think this is going to be our final question. We have somebody who is referring to the fact that you mentioned that the first line of treatment for young children is parent training, and so their question is, are you concerned with the number of young children receiving medication, and especially since there can be an impact on brain development?
I'm concerned about the relative imbalance of use of medication relative to use of behavior therapy. And it's almost twice as many young kids get medication than get behavior therapy, which runs counter to the guidelines and to what we know works best with young kids. I'm also concerned with the possibility of side effects. One of the adverse side effects of stimulant medications, for example, is potentially some growth reduction. So reduction in the velocity of growth, height, and weight. And that's obviously, this is a sensitive growth time, 3 to 5 years old. And so one would want to be, fairly conservative in terms of using a treatment that might inhibit growth during a prime growth period in a child's life. So yeah, I'm concerned. That said, I certainly know of and have worked with children who not only responded to medication, but seem to require it. And so it's not kind of thing where you never have medication being administered to this age group. But I think we need to be much more conservative in prescribing medication to this age group, and we need to help communities to develop more resources for behavior therapy, because that is certainly the primary way we want to go with this age group.
Great, thank you. Again, thank you to Dr. Depaul and to all of you for joining us. This concludes our webcast.